Hello friends, this video is on SIADH, syndrome of inappropriate ADH secretion. This can be asked as a short note in first prof level, second prof level, or even in the final year in medicine, and MCQ can be asked on this topic in various PG entrance exams. So therefore, this topic is relevant for the entire medical curriculum. And as usual, I'll be talking about the pathophysiology and also be adding some physio plus points which are exclusive, which you can write and score heavily in your exams. So let's begin and first start from the basics. The condition is syndrome of inappropriate ADH secretion. So to understand this, we need to first understand what is appropriate ADH secretion, which means when is it that the ADH is normally secreted, or what are the appropriate stimuli for the ADH secretion. There are two important stimuli which normally cause the ADH secretion. Under normal circumstances, osmolality of the plasma is the most important stimulus for the ADH secretion. That is, if there is hypertonic plasma or hyper-osmolar plasma, then there are osmoreceptors in the hypothalamus. They sense this hyper-osmolar or hypertonic plasma. Its tonicity is sensed by the osmoreceptors in the hypothalamus, and they would then cause release of ADH from the posterior pituitary gland. Now this ADH will reach to the renal tubules, and from the collecting duct via aquaporins, it will cause reabsorption of water. Increased reabsorption of water from the collecting duct into the plasma, and therefore the plasma which was hyper-osmolar, its osmolarity or tonicity will be corrected. This is how ADH is normally secreted. The other important stimulus for the ADH secretion is the volume, circulating blood volume, circulating plasma volume, particularly in the second stage of circulatory shock. You know, when there is more than 500 ml blood loss, and if the person goes into second stage of circulatory shock, then ADH will be secreted, because ADH is going to retain the water into the plasma, and that will increase or expand the plasma volume. So the other important stimulus is when there is hypovolemia. Remember, either hyperosmolarity, that's the most important stimulus for ADH secretion, most appropriate stimulus if we can say so, and hypovolemia will be another stimulus when ADH is secreted, and then it retains water into the plasma and the volume is corrected. Now that being said, we will now have a look at why it's called as inappropriate ADH secretion, SIADH. Why it is called inappropriate ADH secretion? First of all, we already are aware that for any hormone, the disorders are of two types, hyposecretion and hypersecretion. So first point that you can remember is that hyposecretion of the ADH results in what is called as diabetes insipidus. There will be excessive urine output and excessive diuresis. So that is hyposecretion of ADH, diabetes insipidus. Now opposite of that will be the, of course, hypersecretion of ADH, and resulting in the condition called as SIADH, syndrome of inappropriate ADH secretion. So it is going to be a hypersecretion of ADH. Now when we say hypersecretion, why are we also calling it as inappropriate? Let's see that. Imagine that the plasma volume is normal, which means there is no requirement of the ADH right now. or it's a normotonic plasma or even hypotonic plasma. Let me add here, whenever there is hypotonic plasma, normally speaking, if the plasma is hypotonic, then ADH is suppressed and it results in diuresis. Water will be lost from the plasma into the urine. That's the normal case. But imagine that the plasma is normotonic, it is becoming hypotonic because of the ADH, and yet ADH is not getting suppressed, it is getting released and released and released. It would then be called as the inappropriate ADH secretion. So that's why it's called inappropriate ADH secretion, because plasma volume is apparently normal, plasma tonicity or osmolarity also is either normal or it is becoming hypotonic. Imagine that the ADH is started to be secreted and it has retained water into the plasma. Plasma has become slightly mildly hypotonic. Now the ADH secretion should be stopped. But no, ADH is continued to be secreted and therefore it retains more and more water into the plasma. Plasma becomes more and more hypotonic. This is the reason why it is called as inappropriate ADH secretion. So, it's the inappropriate ADH secretion. Why does it happen? What are the conditions in which this inappropriate ADH or excess ADH secretion occurs? Generally in physiology, we talk about certain conditions like stressful situations, or conditions like surgery. These are the situations when ADH is secreted excessively. But apart from that, there are four important pathological conditions or four major causes of inappropriately high ADH secretion. Malignant tumors. If you are a second year student or a final year student, you must have already read that there are certain tumors which cause ectopic secretion of certain hormones like ectopic ACTH secretion, etc. So also these tumors, some of them like bronchogenic carcinoma for instance, is known to secrete excessive and ectopic ADH secretion. Apart from that, there are non-malignant pulmonary disorders. So you can remember like this, if it's an exam short note, remember two conditions related to the lungs. One, malignant tumors in the lung, and non-malignant pulmonary disorders like tuberculosis, like pneumonia, or even positive pressure ventilation being delivered to the patient. It can cause excessive ADH secretion. There are cranial tumors, rather cranial disorders like head injury or meningitis or increased ICT, increased intracranial tension, is known to secrete the ADH or excess ADH secretion, and there are certain drugs. So these are the four major causes, two related to the lungs, one related to the cranium. You can remember like this, that since ADH is being secreted by something in the cranium itself, the posterior pituitary, so therefore cranial disorders, and then the drugs, which can also cause excessive ADH secretion or inappropriate ADH secretion. Now let's see what actually happens in this condition, the pathophysiology of the SIADH. There is inability to excrete consumed water load. That's primarily what happens with the excessive and inappropriate ADH secretion. As I have mentioned already, that if you consume water, that water is absorbed into the plasma and plasma temporarily becomes hypotonic. Now at this stage, what should ideally happen is ADH should be suppressed, ADH secretion should be suppressed, and there should be diuresis. But that does not happen. So consumed water load is making the plasma hypotonic, and ADH is, there is no suppression of ADH. ADH is being inappropriately secreted. So water load cannot be excreted into the urine. Inability to excrete consumed water load, and therefore there is hypertonic urine. Obviously, I mean, if the water load is not getting excreted into the urine, urine will become hypertonic and plasma will become hypotonic or hypo-osmolar. All that water will be retained in the plasma as ADH is being continuously and excessively and inappropriately getting secreted. And therefore, as a result of that, there is increased total body water. Obviously, the total body water will increase. Water is getting retained in the body. Another thing that is a hallmark of this condition is the hyponatremia. You should not miss this while writing your answer. The hyponatremia is the hallmark of this condition. Reduced or decreased sodium concentration in the plasma. What happens as a result of hypotonic plasma is that there is swelling of the cells. We already know this, that if the circulating plasma around the cells, if it is hypotonic, it means water from the plasma will enter the cells and therefore there will be swelling of cells. So what will be the manifestations of this, particularly if the nerve cells are swollen or any other cells getting swollen? What are the manifestations? There is headache, nausea, vomiting, there are behavioral changes and eventually stupor, coma and seizures. So increased water entry into the cells and the cells getting swollen up will result in these manifestations. So this is how the SIADH will manifest itself. Let's see something more extra or physio plus plus regarding the hyponatremia. Already we have seen that there is going to be hyponatremia. That's the hallmark of this condition. It starts as dilutional hyponatremia. Dilutional hyponatremia. Those who are first prof students may not clearly understand this term, dilutional hyponatremia. So here is the condition: sodium and water. Now there is a possibility that in certain conditions sodium is lost out of the body and therefore there is absolute hyponatremia, absolute reduction in the sodium concentration. That's one reason of hyponatremia. The other reason is sodium is normal, apparently normal, but water gets retained in the body. Water gets retained in the plasma. So relatively now water is excess and relatively the sodium is low. After all, it's a relative concentration, sodium relative to water. So if the water increases in the plasma, now there is relatively low sodium and more water. So it's called as hyponatremia, but it's called as dilutional hyponatremia, as if the water has increased in the plasma and therefore sodium has got diluted, just to put it simply. Now what happens as a consequence of this? This you can write as a physio plus plus and it will fetch you extra marks. Dilutional hyponatremia, that's the starting point. We have already said that since water has been retained in the plasma, there is increased circulating blood volume. Plasma volume has increased, blood volume has increased. Venous return to the heart increases. Obviously, the circulating blood volume has increased. So this venous return to the heart increases and therefore the right atrial filling will also increase. Atrial filling will also increase. More and more blood is filling in the atria. So atrial filling will increase and there will be atrial stretch. Atrial musculature is stretched, and because of this stretch, because of this increased volume, there is release of ANP, atrial natriuretic peptide. This is an attempt to compensate for the excessive ADH. Look, let me just explain this concept a little further. Let's say under normal circumstances, if ADH was secreted and then plasma became hypotonic, what was the cure for it? What was the compensation for it? ADH will be suppressed and there will be diuresis. Water will be lost into the urine. From the plasma, water will be lost into the urine. That's in a normal case. But here, ADH is not getting suppressed. That's the problem. ADH was supposed to correct the plasma osmolality by getting suppressed. That's not happening here in this condition. So there has to be some compensatory mechanism for it. Yes, the compensatory mechanism is in the form of atrial natriuretic peptide. So increased circulating blood volume causes release of ANP, atrial natriuretic peptide, from the atrial musculature. Now this will be released by the atrial cells and via circulation it will reach the kidneys, and here it will cause natriuresis and diuresis. Obviously, wherever the sodium goes, water follows. So this ANP will cause natriuresis, sodium loss into the urine, and therefore water loss into the urine. Yes, that was our major problem in the first place, that ADH is getting secreted excessively, inappropriately, so water load is not getting excreted properly. That was the problem. Partially it has been resolved, that ANP now it is causing natriuresis, that is sodium lost into the urine, and because sodium is lost, water also follows and water lost into the urine. So diuresis is happening because of this ANP. Now what happens is, although it is acting like a compensatory mechanism, it is trying to remove the water load into the urine. It may bring the volume back to normal. Remember, we saw in the beginning that the blood volume increases because water was retained into the plasma. Now, by water lost into the urine, the plasma volume might return to normal. And now this condition may proceed to become euvolemic hyponatremia. So the condition that started as dilutional hyponatremia, now it is likely to become euvolemic hyponatremia because volume might return to normal. So it is euvolemia, but sodium was lost into the urine and therefore sodium levels drop further and hyponatremia gets worsened. So euvolemic hyponatremia is the consequence of this condition, SIADH. Now, another physio plus plus that you can write in your, if this is asked in the physio exam, it's not routinely asked in the physiology at first prof level, but it can be certainly asked in the pathology, it can be certainly asked in medicine. So diagnostic criteria for SIADH. There is no single lab test that can pinpoint the diagnosis of SIADH. So there are certain things that you can collect as information, and it's called as Barter-Schwarz criteria for the diagnosis of SIADH. There is hyponatremia. As I mentioned, it's a hallmark. Hyponatremia and hypo-osmolality or hypo-osmolarity or hypotonicity, because water is getting retained into the plasma. Plasma is hypotonic, hypo-osmolar. That's point number one, very important indicator. Increased renal sodium excretion. As I mentioned just now, there may be release of ANP. It will cause natriuresis and diuresis, so increased renal sodium excretion. No evidence of volume depletion, and there is no other cause of hyponatremia. So if you take the history, if you examine the patient and there is no apparent cause for hyponatremia and there is no evidence of volume depletion. So in the absence of these, if you find those other two, then it's the Barter-Schwarz criteria. for the diagnosis of SIADH. All right. And now let's summarize the condition again. The SIADH, it's a condition of hypotonic overhydration with hyponatremia. First, remember this: hypotonic, because plasma becomes hypotonic because of excessive water gained, and overhydration, volume expansion state, with hyponatremia. And how do you show hypotonic overhydration with Darrow-Yannette diagram? We have done this even at the first prof level, Darrow-Yannette diagrams to show the condition and how the water lost or gained and what happens to osmolarity. So you can see here that the ECF, this compartment is ECF, here it's ICF. So basically ECF volume has increased, it has become more than 14 liters. So volume expansion, because water was gained, and because only water was gained, therefore the plasma or ECF became hypotonic. So obviously this is hypotonic overhydration. Look at the ECF side. You know that primary changes occur in the ECF. So primarily ECF overhydrated and hypotonic. And because ECF is hypotonic, ECF water shifts into the ICF. So ICF volume increases secondarily. You know that there is a need for osmotic equilibrium, and therefore ECF water will shift into the ICF. And we also saw that there is swelling of the cells swell up. So that's what happens here. ECF water shifting into the ICF. So intracellular fluid volume will also increase, and therefore cells will swell up. So there is a secondary change of increase in the ICF volume. So that in a nutshell was the SIADH. Don't forget to mention those physio plus points that we saw here, and that will get you absolutely brilliant marks in the exams.